Welcome to Tuesday Talks. I'm Seema Kumar, and today we're going to discuss an urgent issue that affects thousands of pregnant women right here in the United States. According to the recent maternal health report from the National Center for Health Statistics, which is part of the CDC, maternal mortality rates in the US have improved, but they are still alarmingly high compared to other countries, especially among women of color. This issue demands our immediate attention, and we have to find ways to address the scientific, social, and political challenges that hinder the progress in women's health research. To guide us through these challenges and to have a conversation about it, we have today with us Dr. Elizabeth Garner. She is a distinguished OBGYN physician, a researcher, and healthcare executive with more than 30 years of experience in the field. And currently, she serves as the Chief Scientific Officer at Ferring Pharmaceuticals United States. Dr. Garner has been advocating for women's health research since she graduated from Harvard Medical School. She has held Chief Medical Officer roles for UBS-EVA and Agile Therapeutics. Both are women's healthcare companies. And earlier in her career, she held leadership roles in medical affairs at Myriad Genetic Laboratories and clinical development at Abbott Laboratories and Merck Research Laboratories. Elizabeth is currently board chair of the NUA Surgical, a startup company developing solutions for maternal health, and she was also the immediate past president of the American Medical Women's Association, whose mission is to advance women in medicine, advocate for equity, and ensure excellence in healthcare. Welcome to Tuesday Talks, Elizabeth.
Thank you so much, Seema. I'm really looking forward to this discussion.
Yeah, thank you for being here at Cure. And there's so much to discuss, right?
Yes, there is.
But before we get into the current state of affairs on maternal health here in the United States, let's talk a little bit about your background and how your upbringing in Nigeria, right, has not only influenced what you're doing here in the United States, but what led you to an understanding of the social determinants of health, which play a big role in, how we look at diseases.
Thanks so much for asking that question. I think it's a really important part of my journey for sure. So yes, I was born in Nigeria. Right during the Biafran War, for people who are old enough to remember that terrible tragedy.
Yes.
And I would have been, had Biafra won the war, I actually would have been a Biafran, not a Nigerian.
Yeah.
But yes, it was a terrible time. Of course, I was a baby at that point. But then growing up in Nigeria over the years, I really sort of started to realize, wait a minute, there's something not quite right here. It seems that women are not quite treated in the same way as men. And then over the years, unfortunately, I had several relatives of mine, cousins, aunts, that died from really what I believed were preventable deaths, right? And that is directly relevant now to what we're talking about today. And so from a pretty early age, and then actually in medical school as well, I would go back, during the holidays and see these things that were happening and I was in an OBGYN setting, right? So I really kind of pulled these things together and realized we need to do something about this. And then over the years, especially through my industry years, I started to realize, my goodness, this is not just a problem of, sub-Saharan Africa. First of all, it's a global problem, and it is certainly a U.S. problem, as we'll talk about today. We have major problems when it comes to maternal health in the U.S.
And right here in New York City, and here in the United States, which is one of the most technologically developed nations, and right here in New York City, capital of the world, maternal mortality rates are, and women's health just in general, way, almost on par with the global South.
Right, which is shocking, right?
Yeah.
With all of the technologies you said, with all of the resources that we have, and I'm sure we'll get into some of the reasons for that, but absolutely. So.
Yes, and I'm sure that one of that is going to be social determinants of
question.
Health, right? But let's start with the CDC report that was just released last month, right? The report revealed that the 2022 maternal mortality rate decreased compared to the pandemic. We saw a big spike in 2021. But even though, there is, some improvement, we're still lagging behind dramatically, in fact, compared to other wealthy, quote-unquote, countries, right? So can you share a little bit more information about the statistics, starting with, how the current decrease in mortality rate occurred and, how they compare to what's happening in developing countries?
Sure. So why don't we start with developing countries since
Yeah.
we were already talking about the global situation. So for sure, the U.S., as it compares to, say, high-income countries, does not look that great, actually. So if you look at some of the really, really sort of the best in the world, it's really sort of the Norwegian countries, Sweden, Denmark, who have less than 10, sort of 1 to 3 women who die per 100,000, and that's how we count this, deaths per 100,000 live births, right? So those are very, very low numbers. In the U.S., the most recent from the CDC, as you said, we're looking at about 22 women dying per 100,000 live births, which, as you said, is better than it was back in 2021. But still, we're not doing well when we look at sort of what we should consider our comparison countries, right?
Benchmark.
Exactly, if you want to call it like a benchmark. So not doing well. Now, certainly if you look here in the U.S., there are clear differences, right? Really, it's sort of where you live and what your color is really kind of determines what you're going to experience or what people in your community are going to experience. And as you said, we can talk more about social determinants of health, but for sure there are disparities, right? So as you look at the new data from the CDC, you're still seeing quite clearly, right, that Black women in particular, although back in 2021 the rate was 70, right, compared to actually in 2021 33 for the overall, and then now we're still about 50, 49.5 is the number for Black women. So improvement, sure, but a lot of ways to go, right?
Yes.
And then what's interesting is I don't know if you showed the graph, but you see the graph that goes up and then peaks and then sort of we start to see it going down. What that tells you though, because you'll hear people say, well, it's COVID, it was all COVID and now we're returning to sort of pre-COVID rates, which is true. But if you look sort of pre-COVID, we were already starting to go up. So there was already something not quite right. So even though, yes,
the starting point itself was less desirable, right?
So clearly a lot of work to do since the COVID pandemic.
And how do the stats look by race?
Right. So Black women, and I was just looking at this actually just to make sure I get it right. So currently, right, we went from, for white women, 27 in 2021 to 19. So reasonable improvement, but still, again, looking back at sort of how we should be as a high-income country, not so great. Hispanics were 28 down to 17. Asians, 17 down to 13, right? And they seem to sort of overall be doing the best. If you want, that's not the best, but better than other. And then, of course, Black women, as I talked about, 70 back in 2021 and now 50 or 49.5. So improvements everywhere.
Improvements everywhere, but not satisfied by any means, and a lot of work to do. What about by age? I mean, how does it separate out by age?
Interesting, and this we sort of know already, right? I mean, in some ways you could say that we are, as women, sort of supposed to. I don't mean that, by definition,
biological clock is ticking.
Biologically, right? When we're younger, we're stronger, we're healthier, we're just in generally better shape to have a baby, right? So the rates in there are definitely lower versus if you look at what we call advanced maternal age, which I've never liked. That's 35 and older, advanced maternal age. But as you get older, certainly into the 40s, around there, and try to have a baby, it's much more likely that bad things are going to happen. And that's because women are more likely to have hypertension, they're more likely to have obesity, they're more likely to have sort of other underlying conditions that give them higher risk.
So even though there is progress, there is still a lot of work to do, as we said. And if you think about the ethnic disparities that still persist, right? How do we think about this? Our healthcare system, how's it tackling it? It's broken, right? And what role do you believe that hospitals and policymakers should make and take, in addressing this?
Yeah, there's a lot there. There's obviously, before sort of really thinking about the systems, there are the underlying conditions, right? So I think it's important for people to know that age, as we talked about, obesity is a risk factor, underlying conditions are risk factors. So there are certain things that are clear risk factors, right? And then there are clear causes, right? There's the bleeding that happens. That's the most common.
Yeah.
And then there are hypertensive conditions like preeclampsia, right? And then infections, right? Especially after C-sections and things like that. Those are pretty high percentage of the reasons for maternal deaths. But then the really surprising one, which I think is related, and that's why I'm saying it last, not only that it's shocking, but it's also related to some of the systemic problems that we're going to talk about, is mental health, if you can believe it. This is one of the leading causes of maternal death.
Wait, so
Shocking.
mental health,
Yes.
you know, the state of mental health, how healthy you are as it relates to your mental health has a impact on, you know, the rates of maternal mortality.
Directly.
Directly.
Yes.
Wow.
So
What do you think the reason is?
Oh, I mean, there are many, right? I mean, like, think about life these days and COVID. I mean, everybody's stressed,
We're all
right? So
stressed
there's a
out, yeah.
baseline, I think, of stress. Add to that a pregnancy, right? Add to that childbirth. So now you're adding either your first baby, which is the most traumatic of all, or you're adding to your family. So the stress levels naturally go up. We don't have good supports for women in that postpartum period.
Yes.
If you look at sort of what are the kind of the two big killers, mental health, postpartum depression, which is being talked about, thankfully, a lot more.
Yeah.
It's getting to be unstigmatized, and we can talk about stigma. I'd love to talk about that later. But so postpartum depression, and then unfortunately, opioid use and opioid overdose, which is very, very common, and that happens quite frequently in women. So those are sort of the big issues. But if you can imagine, in some populations, mental health is the top reason for maternal death. And that's something that when I read those a couple of years ago, I was shocked.
Wow.
And it's gotten worse as well. So that's a big issue. And that, I think, ties into some of the social determinants of health.
Yeah, speaking of which, let's talk about the social determinants of health, right? Like, you know, what are some of the key factors that, you know, come into play as you think about this? Because it's to some degree, it becomes a complex algorithm, right?
Yes.
Right?
Oh, yes.
So you take the health, you take the age, you take the race, and you take the zip code, and then you take so many other things.
Right.
And then you have a complex algorithm that could determine, and mental health, right?
All of that.
And if age has an impact on how well you do, then, you know, maybe even that worry of, oh my God, I am 40 years old and I'm having a baby, you know, that itself can cause stress.
Absolutely. Absolutely. So everything you mentioned, and it's very complex.
Very complex. So let's focus on the social determinants of health. So speak a little bit more about that.
Yeah, so you said zip code a few minutes ago, and I think that is just absolutely critical. So there's no doubt that where you live in this country has a lot to do with how you are going to do in pregnancy and your risk, actually, of dying, right, related to a pregnancy.
Yes.
One of the key issues that I think is so interesting and sad at the same time is what we call these maternity deserts, right? So a maternity desert basically is defined as an area, a zip code, where there's no obstetric care, no obstetric practitioners, and no obstetrics facilities, right? So no hospitals, no labor, wards, and even no maternity, other options, basically, right?
Yes.
So that's a maternity desert, right? In the U.S., it's believed that about 1/3 of counties have maternity deserts, meaning 1/3 of people who live in the counties of the U.S. don't have access to obstetrical care.
Wow.
Now, why is that a problem? I mean, it's one thing to say, well, we don't have access for, say, cancer care, which is a terrible thing. But you don't die immediately when you have a cancer, right? You do die very quickly if you have bleeding, heavy bleeding after delivery. That happens very quickly, right? Minutes. You need minutes to deal with it. You can die very quickly with preeclampsia, which is one of the leading causes of death. If you don't have care very close to you, that's just basically
it's
you're
just
waiting.
Plain logistics of distance.
Exactly.
Right. Yeah.
So that's a big, big problem.
Yeah.
And for that, I think you sort of mentioned, well, what do we do from a policy standpoint? Well, what's happening in the medical system is that, unfortunately, many hospitals and systems have been taken up by, for instance, PE firms and so on, right? Where there is truly a need, you know, for returns, right, on the investment.
Yes.
So there's huge pressure on hospitals, on hospital systems, CEOs to deliver.
Yes.
Right?
Yep.
And naturally, they're going to look and say, okay, what brings me the most money in my hospital? And unfortunately, maternal health is not really a, you know, it's not a revenue stream, and so those go. So you're seeing,
hey, listen, we've just
down.
Celebrated Mother's Day. This is kind of depressing.
Yes, it is.
Yes.
Yeah, it's sad. So we're seeing basically many of these maternal wards and so on being shut down.
You know, this is crazy because, like you said, you know, this is a basic human thing that happens.
Right. Yes.
Right? Children are born. That's it's like biology 101, right? Like it happens every day. You know, lots, and so this seems like a primary care almost, right?
Yeah, right.
That you need, and so you know, we'll come back to that, right? Because what I'm sort of sensing and picking up is a pattern, right? That leads us to a broader issue beyond maternal health, and that's women's health in general.
Yep.
And the prioritization based on, you know, business needs that they receive, right? So, I mean, but back to what you were saying about, given that the largest killer of pregnant women, Black pregnant women, is preeclampsia, you know, otherwise known as hypertension, you would think that we would be doing research into this condition, but I'm surprised by how little research have been done and no treatments or cures exist, right? Like, why is this, and why aren't we investing more? Why aren't VCs and pharmas investing more in this particular area of research?
Yeah, this is a tough one, and for sure, you know, we know that for years, women's health has been underinvested in, right? So there, you know, many publications and so on that. So we know that, right?
We could have a whole day.
To talk about that, exactly. Yeah. And what that means is, if we're not investing, if there's not money been put into this, then we don't understand the science, because that's where a lot of the money needs to go, right? Is to understanding sort of the basic stuff of what's happening. And preeclampsia, I think, is a great example, as are, you know, things like preterm birth and, you know, postpartum bleed, all this stuff, right? We have to better understand it.
Yep.
Without the science, it's very difficult for industry, for instance, to be able to actually design and understand, you know, like figure out drug development, right? If you don't actually understand the mechanism that's leading to the condition, how do you find, you know,
it
specific...
starts with the science.
That's right.
And then you figure out how to meet the need.
Directly address it, right? We've seen that happening beautifully in the oncology space, right? There's been so much science, and now we have targeted therapies. We can literally say, oh, that's the mutation, and we're going to attack that mutation. We don't do that in women's health.
Thankfully, we did make a lot of progress on breast cancer, you know.
Thank goodness. That's one area of women's health.
That's one area of women's health that's,
for sure. Absolutely. So, you know, back to the problem of not having, you know, targeted therapies, there are many examples, even recently, of products that have been taken to the FDA to sort of say, hey, we want to, you know, look at this, we want to get this approved, et cetera. But there's not enough science for the FDA to be able to say, yes, we're going to approve this. We have enough in terms of safety and efficacy. If you can believe it, in all of FDA's years of existence, there have only been 9 drugs that have been developed specifically for obstetrical use. 9.
Obstetrical use overall.
In pregnancy. Anything.
We're not talking about preeclampsia or specific conditions.
Everything related to obstetrics and like things like hypertension, preterm labor, all that other stuff.
So it's 9 approved drugs.
9
out of what? 4?
Thousands.
Yes.
Right.
Yes.
Of drugs, 9 of them. And that's a number from FDA. And FDA is not happy about this either. And so we are all motivated.
But they can't approve drugs without the data. And data cannot come without research. And research has to depend on basic research and all of the above.
Right. So, and I think another challenge is that, you know, over the years, You know, several of the of the pharmaceutical companies have decided to sort of go, you know, let go of women's health.
Yep.
And a lot of that is that many of the drugs that were bringing good revenue, such as contraceptives, were going generic. So it's like, let's you know, like, right? And then without the science, there hasn't been anything really they can pick up. Now, there have been a couple, I think, of really interesting products that have been developed recently, right? We've got the Menopur, that's a Ferring drug. We've got the menopause product. We've got a product now for postpartum depression. They aren't doing that well yet. And so investors who are watching this going, wait a minute, you know, I'm not quite ready because I'm not seeing those returns that I want and need, right? So it is a little bit of a vicious cycle. But the good news is, and I'm sure we'll talk about this a little bit more, is it finally feels like women's health is now on the forefront of everyone's minds. And I do believe we're going to see more investment.
Yeah, it feels like, you know, reminds me of antibiotics or rare diseases where, you know, the business model needs to be,
that's right,
you know,
exactly.
rethought a little.
Exactly, and that's something we talk about a lot in the women's health space, which is we have to make that business case. Got to make the business case. We're getting there. There's more and more evidence around the fact that, you know, addressing women's health issues will lead to certainly economic advancements, right? Gains. We know it's obviously going to help women, and when women are healthy, everyone else is healthy, and we just do better, and the economy does better. So there's that. I think what we still need is that business.
You still need the market size.
Exactly.
You need You need, you know,
all the things that an investor needs.
All the things that an investor needs.
Yes. So we're
working on it. So that's good. Good. We need to be working on it, right? So it does, though, like you said, seem like women's health is having its moment right now. You know, with the White House launching its new initiative, the First Lady standing behind, you know, on this whole women's health research initiative, and it looks like everybody's jumping on the bandwagon. Do you believe that this is a moment for new innovation and, you know, for women's healthcare companies to, you know, really spin up? Or do we think this is sort of like a, you know, fleeting 15 minutes of that moment?
Yeah, it's a great question, Seema. I ask myself that question every single day because I am, unfortunately, a little bit of a pessimist. And when I see things like this, I'm like, yeah, okay, you know, now it's in the limelight, but, you know, another year and everybody's going to have forgotten about this. I don't think so, right? And I've talked to a lot of folks who've been around, you know, longer than me, who have said, you know, yeah, there have been these upticks over time, you know, but this is different. There's something different here. And I think there are a lot of things that are different. One, I don't think we've ever seen this reaching the White House. We've never seen a White House initiative on this. We've never seen the president, you know, with an executive order for $12 billion of research, you know, dollars in the government. I mean, right? So something has changed. Women are speaking out more too, so there's a lot more pressure, I think. So I do believe that this is a moment, and I think it's going to be sustained. I sure am not going to let go of it, and I think, you know,
I'm crossing all my fingers and all my toes. Yes.
Me too. And I think this is the first time I've ever seen actually investors also being super interested. I've not seen that before, right? Where people are, you know, literally like, this is super exciting. How do I get in, right? What can I do, right? So that's super exciting.
That's great. That's great. You know, high tide can float all boats.
That's right.
And also when all the key stakeholders come together, government, industry, VCs.
Exactly.
Researchers.
Exactly. You absolutely read my mind.
Yeah.
There's actually a talk that I give. It's exactly that. I talk about the ecosystem and how we all have to get together.
Yes.
There's a great example of that. At the FDA, for instance, Dr. Pazdor on the oncology side.
Yes.
And you can actually see, I mean, there's a beautiful graph that shows like when he started, when he put together what he called the Oncology Center of Excellence at the FDA, he brought everyone together, all the groups that you talked about, and together, this is what's happened in oncology. So I hope that we can replicate that by truly bringing the whole ecosystem together.
Same thing we saw happen in HIV.
Yes,
right?
yes,
And
another great example.
Another great example.
Yeah, that's a great example, actually.
And so and to some degree, for a while there, we had that same kind of a thing during the pandemic. we're
Yes,
working
yes.
on the
I mean,
vaccine, right?
Right, and how quickly things got done, right? That's
things
another
got
one that I think we really need to.
yes, and
It doesn't have to take 7 to 10
yeah.
years. We can do it faster.
And women's health issues are just as urgent and important and as much
Absolutely.
of a crisis in a
Yeah,
pandemic.
you're so right.
You know, in another way. And so the focus on this is really nice to see.
Yeah.
And we hope that you know, this will really take us to the next level
Yeah.
in solving many of the women's health
Yeah.
issues.
Totally
And
agree.
you know, before we go, I just wanted to ask you, where do you think we will be in maternal health in 5, 10, 15 years from today? 5 years from today, we're celebrating, you and I are sitting there, we're having a glass of wine, celebrating Mother's Day, or maybe our, you know, our families are sort of honoring us. Where do you think we will be?
Yeah, so my hope is that in 5 years there'll be much more science, right? That's been done that is allowing us to better understand all of these underlying conditions, right? So that's one. I think there will be some advancements in science.
And in fact, I mean, just not to interrupt you, but partly because women's bodies and biology is so complicated,
Yeah.
we were actually excluded from research.
Yes,
Because
yes.
it's not easy. We're complicated. And
That's a very important point. So
Yes.
1993 was the first time, right, that women were invited into clinical trials.
And now
So
we
yes,
need to go down into the basic
Yes,
research because there is a, you know, there are sex-related differences.
That's right.
Biology differences, and so this requires a lot more investment in the basic research as well.
That's right, and I think we'll have made progress there. The other place that I'm very hopeful within the next 5 years that we will have improved in, and that we haven't really actually talked much today on, which I think is really important to point out, around sort of the structural issues,
yes.
is all the issues around racism, right?
Systemic racism needs to be,
racism,
you know,
bias, right?
Stigma.
Dismissal of women, especially women of color.
Yes.
This has now really been brought to the forefront as well. We're talking about it.
Yes.
And women are talking about it and saying, absolutely, I'm not gonna,
put up with it. It's not all in my head.
Thank you.
We'll talk about that book another day.
Exactly.
Yeah.
So I'm hoping that in 5 years we'll be doing much better job there.
That's great. Well, here's to that. Thank you so much for joining us here at Cure and for shedding light on this very, very important topic. Thank you, Beth.
I really appreciate
it. Really appreciate it. And our next week's Tuesday Talks, we will be discussing Femtech and how a new startup accelerator, the Fierce Foundry, is helping female-owned businesses develop their ideas into successful commercialized businesses. Thank you all for joining, and for more information on our work here at Cure, go to www.wewillcure.com. See you all next week.